This is Teresa Pablos, editor-in-chief of Dr. Bicuspid. I'm with Tom Viola, pharmacologist extraordinaire, for another episode of Dental Dose. And today we're talking about lidocaine. So, lidocaine, what do we need to know, Tom? Give us the high-level summary.
Well, everybody loves lidocaine. Yes, lidocaine, lidocaine, lidocaine. Marsha. Everybody loves lidocaine, right? Why not? Why wouldn't you love lidocaine? It is a great anesthetic agent. It's got so many advantages. It's hard to keep track of them all. But is lidocaine really the go-to anesthetic agent? Is it really the anesthetic agent that should be held in as high regard as it is? Well, let's see. Let's
I think we're going to get some interesting content here. So let's see. So what's point number one?
So point number one is lidocaine has always been the gold standard. Everyone who's ever compared an anesthetic agent to another anesthetic agent has almost always compared that anesthetic agent to lidocaine. Why? Why would lidocaine enjoy this, most favored nation? Why does it have the status that it does in dentistry, whereas there are other anesthetic agents that work just as well? Okay. First reason I can come up with is it's been around forever. Okay, it's been around since the 40s. So talk about longevity. Okay.
Yeah, that's a long time, and to maintain that kind of status too. I feel like so many other agents and in pharmacy medicines, agents, all of that good stuff. There's something new, something better. Mm-hmm. To be around from the 40s is a really long time to maintain its status.
Yeah, and let's face it, mepivacaine didn't come too long after. But Carbocaine, mepivacaine isn't anywhere near as popular as lidocaine. And why? Because lidocaine just came first, okay? And so there was a lot of prestige with the fact that lidocaine came on the scene at a time when we really needed it the most. Esters and amides were always an issue for us in dentistry. Which one should we pick? Our favorite was, the first anesthetic used in dentistry was an ester, cocaine. We don't use it anymore as far as I can tell.
But I don't know that story. That might have to be an episode one time, the history of cocaine in dentistry, because that sounds so fascinating. But that's not today's episode.
Well, let's put it this way. If you still used cocaine in practice, no one would ever call out for an appointment. Everybody would show up hours early. Nobody would cancel. Your day would be just flying by because you'd be using cocaine. Be great. Yeah. Okay. So anyway, push that to the side. All right. Mm-hmm. So at the time, we were using an ester called Procaine, right? Novocain. But Novocaine's greatest issue was the potential for allergenicity. Esters were broken down in the bloodstream, and depending on what the thing was that esters were broken down into, if you were allergic to that thing, guess what? Well, it's in your bloodstream already, so it's like getting an injection of something you're allergic to.
Not same issue as with Articaine, correct?
So Articaine saved us in a way because Articaine was...
Yes.
Yeah, Articaine was the amide that's metabolized like an ester. You got it, Teresa. You got it.
I got it was the opposite. It was the opposite.
You remember that. That's good. Awesome. So Novocaine was, can't we do better? Okay, well then lidocaine comes along as the amide. Now, amides don't cause the same amount of allergenicity. As a matter of fact, it's very rare to have an amide allergy. So the amides, and lidocaine was the first, gave us a safety net, something that a level of safety that we didn't have with the esters. So we gravitated towards lidocaine, but lidocaine had some other positive features too. It didn't cause allergies, we knew that, but it was relatively easy to use and predictable. At 2% concentration, you just knew what you were going to get from lidocaine, all the good and the bad. Okay, so you knew that you can titrate the volume and get the effect you were looking for. So first thing is what? It's been around forever, right? Second, it has this long, impressive record of reliable and safe use. So it's been around for so long, and really not many people have anything bad to say about lidocaine. So that endears it to us as well, right? Okay, so lidocaine's been around forever. It's safe.
It's predictable, kind of what you said, which is really important in dentistry.
Absolutely. You knew what you were getting. You didn't have anything about allergies really to worry about. Life was good with lidocaine. So what went wrong with lidocaine? Nothing. We just got other agents that we could use when lidocaine didn't cut the mustard. But why? Why didn't lidocaine cut the mustard? Well, a couple of things. Number one, lidocaine is only 2%. And people think, well, What's wrong with that? But realize the way anesthetics work is that anesthetic molecules have to cross layers of tissue, membranes, right? Well, it's not a 100% efficient process. So every time an anesthetic crosses a layer of membrane, you lose anesthetic molecules. If it's a very large nerve you're trying to get through, then if you only started out with this many molecules, you're going to run out by the time you get to the halfway through. So that's where 3% anesthetics like mepivacaine and 4% anesthetics like articaine and prilocaine are superior because they offer more molecules in the cartridge to get the job done. But if you want to look at lidocaine as like, the all-purpose anesthetic agent at 2%, wasn't so bad, okay? Plus, lidocaine's available everywhere. Go to Target or Walmart or whatever, go to one of these big box stores and walk up and down the first aid aisle. Tell me how easy it is to find something that has, pain reliever for scrapes and burns and injury that doesn't have lidocaine. Everything has lidocaine. So your patients know about lidocaine. We know about lidocaine. They know about lidocaine. And then there was Orachix.
There was what?
Orachix.
Orachix.
So Orachix is an EMLA, a eutectic mixture of local anesthetic agents. And Orachix is a lidocaine prilocaine combination.
Oh.
When you combine those two anesthetics together, you get magic called an EMLA, okay? And Orachix is something you put directly in the pocket, and it's on its own, it's a great anesthetic agent. So all this means is that we just love lidocaine to pieces because it's everything we want in an anesthetic agent. Yeah, 2% could be better. But there's, as you know, I'm going to say soon, Teresa, you knew you were waiting for it, right? You knew it was coming.
I think so.
There's a downside to lidocaine.
What?
What's the downside? Well, everybody loves lidocaine. What's the problem? Okay, so the problem with lidocaine is that it's only available with epi, with epinephrine.
Yep, I know where this is going.
Mm-hmm. So you could get lidocaine in 2 flavors, with epi or with epi. Which would you like? What do you mean? Well, you can have it with the 1 to 50,000 dilution epinephrine or the 1 to 100,000 dilution epinephrine. There's no plain? No. Well, wait a minute. I remember, Viola, when there was a plain lidocaine. There was. I think it's got to be over 10 years now that lidocaine plain was discontinued.
Why?
Well, that's
do we know?
What happened, right? Okay, so lidocaine is a pretty potent vasodilator. And that means in English, you can't really use it without epi. So if you try to use plain lidocaine, you probably got about 20 minutes, which doesn't really work in the dental office. Okay. Or for that matter, anywhere you're trying to use dental anesthesia, right? Okay. So all right. So what about the people who can't get epi? Who? Okay. I'll rattle them off for you, okay? Who's the first patient that can't get epi? Where the medical doctor says what? No epi for you, okay? Medical doctor says no epi? No epi. That's it. Sorry. Who's the second patient? Patient who doesn't want the epinephrine. And there's a few of those too. Like, what?
Are there really? That actually surprises me. I wouldn't have known that.
It's like they place an order. No, I don't want it. Don't give it to me. All right, well, no, can't give them epinephrine. They don't want it. That's it. And then what? And then you've got the patients with sulfite allergy.
Mm-hmm.
You and I went over this when it came to Articaine. Remember this?
Yeah.
Sulfite. Yeah. Okay. So, patient with a sulfite allergy. What does that mean? Okay. Every cartridge of epinephrine that's made in the United States, because epinephrine is so inherently unstable, is preserved with sulfites. If the patient has a sulfite allergy, they can't have epinephrine. They can't have epinephrine. Guess what? Lidocaine is only available with epinephrine, so now they can't have lidocaine. So who are these people? Exactly. Exactly. So any of those patients where the doctor says, no, before you, or the patient says, no, I don't want it, or the patient says, I have a sulfate allergy, any of those patients, you can't use epinephrine, can't use lidocaine.
So I know it got mentioned in the Articaine episode, but what should those patients use instead?
Well, that's a big problem with lidocaine, and I'll tell you why. Because lidocaine has one big advantage we didn't talk about yet.
Oh,
It is in the
jumping the
scheme.
gun here.
I know, right? So in the big scheme of where anesthetics lie as far as safety in pregnancy,
Mm,
lidocaine was issued. This is when the FDA used to do this before 2015. Lidocaine was issued or placed into category B for safety in pregnancy. So the way this works is the FDA would put the drugs in categories based on how safe they were in pregnancy. A being the best, B, C, etc. Right? So lidocaine's category B. Some of the other ones we've talked about already, articaine, bupivacaine, mepivacaine are category C.
yeah.
So lidocaine's safer, right? Mm-hmm. That's why people love lidocaine, safe in pregnancy. Okay, here's the problem though. Obstetricians are taught this in school too. Well, when they've got a pregnant patient, pregnant woman, pregnant men are on their own, okay? Pregnant women who need dental work, they know that if the dentist calls them or there's some kind of interaction, they're going to say what? Use lidocaine.
Mm-hmm.
Makes sense. Okay. But they
Can I
were
can
taught,
I can I guess?
yeah, go
A
ahead.
pregnant patient that cannot have epinephrine. Is that where
Ding,
this is
ding,
going?
ding. You
All
nailed it.
right. I'm the winner.
You did it. So that's it. So the obstetricians are taught, make sure you ask for lidocaine plain. Okay. So you have an interaction now, after lidocaine plain's been gone for 10 years, have an interaction now with an obstetrician. And the obstetrician says, okay, I want you to use lidocaine. And on your end of the, oh yeah, okay, I got plenty of lidocaine. I'll use lidocaine. But that doc's talking about lidocaine plain, and you're hearing
Mhm.
lidocaine with epi. So it's important to have that conversation with the obstetrician. Like, do you mean lidocaine plain? And if the doc says, well, of course that's what I mean. Well, guess what? You didn't get the memo. Lidocaine plain's been gone for 10 years. So if that's the
That
case,
is a big miscommunication right there.
and why would you not use epi in pregnancy? And the answer is, in some cases, in some pregnancies, epi is contraindicated because mom might have um, issues with using epinephrine. She might have hypertension of pregnancy, eclampsia, preeclampsia. And so, we don't want to add epi to the mix because it could increase her risk of those those bad complications.
So that doesn't answer the question. What can dentists use? What are some alternative options here?
Okay, so this is going to be a tough one, right? Because how how much is the epinephrine causing a problem? Is the epinephrine that big an obstacle for us to overcome? Why, Tom? Just pick something else. Okay, well, a lot of times because epi is contraindicated, we just go with carbocaine, mepivacaine, which is category C, but it's plain. So the trade-off is there, right?
Hmm.
But technically, there is another agent, although we'd be using it off-label, and that would be prilocaine. Prilocaine is also category B, and it's available plain.
Ah,
But
I was about to say there's going to be a but. There's
always
there's never one solution. And it's like this is it. It's perfect.
you'd have to really speak to the obstetrician because while it is listed as category B, there are those obstetricians that just wouldn't even want to touch it with a 10-foot pole because they don't know much about prilocaine. And
Interesting.
I don't even know if the manufacturer of prilocaine really has, I mean, they've got data to support, obviously, the category B designation, but do they have any data to support its use in pregnant women in the real world? Like, has it actually been used? So I think more times than not, even though carbocaine or mepivacaine is category C, most docs, when epinephrine is contraindicated, just end up using carbocaine.
Interesting. That's fascinating. It sounds like Prilocaine might be one of the newer ones for anesthetics. No,
Pralogaine's been around a long time,
no,
but
huh? Interesting.
Pralogaine's Cinderella. Okay, that's
We're
all.
gonna we're gonna talk about this in another episode, so we're not gonna spoil it
Yes,
now. So that's really fascinating. So pregnant women have very special complications with lidocaine. Not all pregnant women, just the ones who cannot have epinephrine.
correct.
And then for patients that otherwise can't have epinephrine because they don't want it or their doctor says no, what are their options if they're not pregnant?
then it's got to be Carbocaine. It's got to be mepivacaine or Prilocaine. If you like Prilocaine and you have it in your office, we'll talk about that in another episode. Prilocaine is definitely an option. It's 4%. It's plain. It's pretty much ideal. But a lot of offices just go with Carbocaine. It's 3%. It's plain. Everybody knows it. It's rather predictable. But the one thing that goes against Carbocaine, and we'll talk about this when we get to the myth busting for Carbocaine, is, relatively speaking, it's short acting. And that could be problematic when it comes to endogenous epinephrine. But I'll leave that as a teaser for our next episode.
Yeah, and so I know that this one's already long, but lidocaine is such a big topic in dentistry. And so again, it's been around for so long, it's reliable, it's safe. When is it going to lose its seat, Tom? What are there other agents in the works or no?
I don't think ever. I think the reason we have 5 anesthetic agents is because they're so hard to make. But I also think it's each one has its own special place. So each one has its own little niche that we can borrow when we need to.
Got it. So we're going to be, lidocaine's going to be around for a while then. This episode will stay topical for a long time. Unlike the episode we did on the COVID-19 vaccines. So if you're watching and are interested in that episode or episodes on articaine or bupivacaine, yes.
Well done. Well done.
Make sure you check out the related reading below. Once again, I'm Teresa Pavlos with Dr. Bicuspid. Thank you so much, Tom, and we'll see you on the next episode of Dental Dose.
Thanks, Teresa.